guys. My name is Sunpil Hwang. I'm from North Alabama Medical Center. Sorry for the confusions before. I'm going to present the case that I prepared here. It's called high-grade B-cell lymphoma in the setting of Janus kinase inhibitors and post-stem cell transplantations. I'm going to give you some brief information about the patients and how the patient present to the hospital. This patient is a 67-year-old female. She has some unique pathological history. She has a Janus kinase 2 positive myelofibrosis in 2019. She has been receiving ruxolitinib, which is JAK1/2 inhibitors. Also, she received stem cell transplant in 2021. Apparently, it was failed. So after that, the patients kept taking these medications for a while. This patient presented to the ER because of worsening right lower quadrant abdominal pain, which was started 3 to 4 months ago after a colonoscopy. This patient received this colonoscopy because of nausea, vomiting, and also some stomach ache, which only positive for diverticulosis. Otherwise, it was unremarkable. After that, the patient has been having some worsening right lower quadrant pain, and the patient also had nausea. However, other review of systems was quite unremarkable. On physical examinations, there was only some mild tenderness on the right lower quadrant area. There's no any guarding or rebound tenderness noted. This is the initial lab of this patient. And as you can see, if you see the CBC, there is some moderate level of anemia and also some thrombocytopenia because of patient's myelofibrosis. On BMP panel, you can see some increased creatinine of 2.1, and LFT was quite unremarkable. Procalcitonin was 0.3, which was a little bit equivocal, and the CEA also was less than 2.2, which is almost negative. On the right side, you can see the initial imaging. So because of this ongoing symptoms, the patient took CT outside of hospital like 2 to 3 days ago. So the right image was the one taken outside of hospital 2 to 3 days before presentation, and the left side was taken on presentation. So it's like 7 centimeters mass was noted, large necrotic mass arising at the cecum was noted, and there's some possible concomitant infections or abscess. So on hospital day 1, several specialists were consulted, and they all thought that this might be a case of cancer because the colonoscopy taken 3 to 4 months ago was unremarkable. So we thought that this is more likely an infection or abscess. So the patient was started on broad-spectrum antibiotics like vancomycin, ciprofloxacin, and flagyl. And also day 3, from the imaging, I forgot to mention it, the patient also had some right-sided hydrourethral nephrosis because of the mass effect. That's why the patient's creatinine was elevated. So urethral stent was placed, and after that, the creatinine was normalized. Keep going on hospital course. On the day 6, however, the patient's symptoms did not improve at all. So the patients actually underwent CT abdominal pelvis imaging one more time. And it shows at the time the patients actually took with the IV contrast because the patient's creatinine was normalized. So as you can see, there's already a large necrotic mass growing from the cecum area too. However, if you see closely, it is actually extending to the right psoas muscles. Also from the reading is encircled the right mid-urethra, and also the patients had some infiltration to the right common iliac artery too. So these all findings were more consistent to the neoplasm. So the patient received another one colonoscopy around day 8. It shows the infiltrative and ulcerated partially obstructing large mass in the ascending colon. And it was biopsied apparently after that the patient was discharged for the further planning of possible chemo or radiotherapy from the hematology oncology side. After a few days later, biopsy was resulted, and as you can see, there's some polymorphic nucleus with high-grade nucleus to cytoplasm ratio, and also they did another staining with CD20, which was quite specific for B cells, and there are lots of B cells was noted. So the patient was diagnosed with high-grade B-cell lymphoma, and the patient was started on chemotherapy, which was rituximab, cyclophosphamide, vincristine, and prednisolone. ruxolitinib was discontinued. So this case is quite interesting case, considering that the patients received colonoscopy, which was 3 to 4 months ago, prior to presentation hospital, which was totally unremarkable. However, in between, in a really short-term period, the patient developed cancer, which was nobody expected. So there are actually 2 points that I wanted to point out from this case presentations. The first one is post-transplant lymphoproliferative disorder. This is disease usually occurs as a result of immunosuppression in the setting of solid organ or allogeneic hematopoietic stem cell transplantation. In this case, as a reminder, again, the patient received hematopoietic stem cell transplantation in 2021, even though it was failed. Incidence usually around 1 to 2% after the hematopoietic stem cell transplantations. Basically, the symptoms is quite unspecific. It's dependent on which organs is involved. So in this case, the patient's involved organ was colon, so the patient has a right side lower quadrant pain. Because of that, the physician should hold a high index of suspicion. The mainstream of this treatment is usually immunosuppressions. The other things I want to point out, one is quite interesting, is about JAK inhibitors. So JAK inhibitors, full name is Janus kinase 1-2 inhibitors, is a mainstream treatment for myeloproliferative neoplasm. However, there are several case reports saying that this JAK inhibitor might be related to the coincidence of non-Hodgkin B-cell lymphoma. It is also in the already only in the observation study level. However, there are several studies published in the blood. One of the core study called Venus cohort, it shows a 16-fold increase in the lymphoma development to the patients with MPN receiving JAK1/2 inhibitor, which is quite a solid number. Also, they did an animal study where the mice with STAT1 gene was knocked out, and they developed myeloid hyperplasia with aberrant B cell, which is a precursor of the non-Hodgkin B cell lymphoma. However, as I already mentioned, this is only on the observation studies level, and it was not established yet. And we still don't know that JAK inhibitor is really correlated with the development of non-Hodgkin B cell lymphoma. However, this patient was on this medication and also developed the non-Hodgkin B cell lymphoma after the patient has been on this medication. So I thought this was worth mentioning during this case report, and I wanted to pinpoint it out. So these 2 things is the key point that I want to say, and this is last of my presentation. And thank you for listening to my presentation. Thank you very much.
Alrighty, fantastic. Thank you so much. Do we have any questions from the audience for Sunpil? Alrighty, I do have one submitted question, it looks like. It was asked if the treatment of the lymphoma improved the myelodysplastic syndrome.
I'm sorry?
This is a submitted question, so I can't really go much further into it. I'm sorry. It says, did the treatment of the lymphoma improve the patient's myelodysplastic syndrome?
No, actually, the patient had the several episodes of hospitalization after this course too. However, for the treatment of lymphoma was actually subsided, but still the patient had myeloplastic syndrome. So the patient has ongoing anemia and thrombocytopenia, and the patient has been receiving a regular basis of transfusion because of that.
Very good, thank you.
Thank you very much.